And good evening to everybody, and welcome to this week's Maternity and Midwifery Hour. My name's Sue Macdonald, and I'm the curator for the Maternity and Midwifery Festivals and the Maternity and Midwifery Hour. And it's my pleasure to be chairing this evening's session. Now, we're week 10 of our 14th series, which is amazing. And what's lovely is we've got 3 guests today. We're joined by Kim Morley, Catherine Owens, and Alison Fuller. And as we do to all of our guests, is we start off by asking them to share a moment of the week. So I'm going to start with Kim. For no particular reason, you were smiling. Please share
Okay.
your moment of the week.
Hello, everybody. My moment of the week has definitely been in the last hour, actually. I received an email of somebody who could potentially help me I have chronic compartment syndrome, which causes me severe pain at night. And
Oh, wow.
somebody's doing a clinical trial and they can signpost me but can't help me directly. And that has been my moment this week.
Oh, wow. So signposting is good.
It is good,
Yeah,
yes.
excellent. Oh, I'm so pleased. Well, that's a great moment of the week to share. Thank you for that, Kim. How about Alison? Can you compete with Kim for that?
Well, I've just returned from a holiday in California and I went in a driverless taxi in San Francisco. It was,
Wow.
I hope nobody minds, it was surreal. But so we did it 3 times, but it was fun.
Gosh, that's a bit science fiction-y for me, I think.
Oh, it was very Star Trek.
Oh,
Yes.
wow. Wow. Oh, thank you for that. That's wonderful, Alison. Thank you for
Mm.
sharing that. And Catherine, how are you going to
I
compete
can't
with
really
these two?
beat either of them, I'm afraid. But my moment of the week has been today, and part of a craft group. And every year we do an annual fundraising event. And what I took away today was never to underestimate the value of wisdom and partnership working. And it resonated with the maternity project because, particularly it's a very diverse group. And some of them are well into their 80s, so I'm in constant admiration of them. But just that wisdom and that partnership working is just vital to day as well as in our professional life.
Fabulous, Catherine. And now just let me know, in this craft group, are they all women by any chance?
Yes, they are. They are.
Gosh, wisdom of women, even better.
Absolutely.
Perfect. Thank you for sharing that. That's wonderful. Thank you, Catherine. Well, I'm just going to do the usual. And for those of you who are old friends, you can have a little mini sleep now if you'd like. But for those of you who are new to the Maternity and Midwifery Hour, I just always like to say where we've come from, because we were born in the great pandemic lockdown of 2020. Because before that time, we had a lot of festivals and conferences and study days and that sort of activity. And those of you who remember the COVID-19 pandemic and the great lockdown, we couldn't go out, we couldn't meet other clinicians, we couldn't do any study days or conferences. And we felt it was really important to have some connection for midwives and student midwives, maternity care assistants, actually anyone who was working in maternity services. Everyone was welcome. And when we initially started meeting, we had a lot of COVID related things, especially about service changes and what midwives and clinicians were doing, and students also, because of course their whole studies were turned upside down and inside out during that time. And a lot of very creative things were done, and midwives were fabulous. I have to always remember that those things that people just rose to do at a very scary time. And we've kind of carried on, and I can't really cope with the fact it's 4 years now, and we're almost back. Well, we are pretty well back to normal. Of course, we now have the face-to-face conferences and festivals, which is lovely, and we've got one next week, which I might talk about a little bit later. But it reminds me also that we were very much able to do the maternity hour because we're very used to recording. We had to get used to using the Zoom, which was a bit of a learning exercise. But what has happened is we've got pretty good at this. I'm going to touch wood quickly, just in case. But it's sort of accompanies everything. So everything we do is recorded. And I'm saying this so just in case you have a power cut, or someone gets online in your house and messes up your Wi-Fi, which happens, or you just have to rush away. This is all recorded and you can access it after the day. And you just need to go to the Matflix, or if you have the link from registering with us, you can just go in straight through there. And we will be sending this link out with the newsletter on Tuesday and as a podcast on Friday morning, 6 o'clock in the morning, for those of you who are up and about at that sort of time. So you don't miss anything. And it means that you can share. We love you to share things. We love that. And it's really important, I think, especially with the topic we're going to be doing this evening, to be able to share and discuss, because that helps you kind of cement the learning in your head, especially with complex issues. I always find it helps to talk to my colleagues about it, and, you know, just share, well, did you understand what that meant? And it just helps you kind of put it in your brain. So do share it. And I'll say at this point, a big thank you to everyone who's working so hard to provide care and services at the moment. You're really appreciated. You possibly don't always feel so, but you are. So good on you. And also, any news? Now I have to always check with my handy timing here about what time it is, just make sure I'm keeping to time. The news at the moment, I'm not going to go into world news because it's all a bit scary, and I'm feeling this is a little oasis of calm. So we really just, all I'm doing really is praying for peace at the moment and just an end to all the horribleness in the world. But I know that's probably a bit optimistic. So I'm going to move on to more things in the UK. For example, have you completed your NHS survey, NHS staff survey? Because they're still reminding us we need to do that. Another week to go. It's all confidential. There's also this big review that's going on, led by the new government, into looking at the NHS. And if you've got any ideas or feedback, don't feel shy about giving them your views, your opinions and ideas that you might have, because we know that amongst our wonderful midwives, our student midwives, we have so many great ideas and so much talent. So give them what they need. Today it's World Children's Day, and that's a United Nations Day, and that's promoting international togetherness and awareness of children's rights. And there is a link on the resources which you have to information about that, as well as the World Vegan Month, I should say, and Men's Mental Health Awareness Month, also a link on the resources. And of course, it's Epilepsy Awareness Month this month. And because this is the focus of our session tonight. And we're going to use this hour really to focus on the challenges especially faced by women with epilepsy during their pregnancy and childbirth. And of course, their families as part of that. You can't take the woman away from her family and her friends and, you know, obviously her baby. And we're going to be looking at how midwives can provide support, advice and care to reduce morbidity or mortality and make that experience better. And also the resources of the charity that we're joined by this evening, which is fantastic. So we're joined by Kim Morley, midwife specialist, and Catherine Owen and Alison Fuller from the charity Epilepsy Action. And Kim Morley tells me she's retired. I don't really believe it, actually, but I know that she's very busy. So it might be true, because I find that especially nurses and midwives who've retired seem to get even busier than they were when they were working, if it's possible. And Kim's got a huge nursing and midwifery career. She's undertaken so many roles. All of these are on the website, by the way. And she's mainly, I think I would say her heart has been around running an epilepsy service and really leading on epilepsy care for women and children, babies. And she's designed a maternity epilepsy toolkit embedded in the SUDEP, that's the sudden unexpected death in epilepsy, an action professional checklist, focuses professionally and academically on safety and reducing the risk of avoidable adverse outcomes. She's also I'm not sure if she is now, an Embrace assessor, and she has represented the Royal College of Midwives on behalf of midwives on the ValPro 8 Stakeholders Committee. She's got a wonderful website. I know she's going to share this with you, but she's got a wonderful website resource, and she works very closely with the Epilepsy Action group to improve knowledge and practice for women and families' experience. And so welcome, Kim. The screen is now yours, and thank you for...
Thank you very much, and thank you for inviting me, and it's great to be back. We were in lockdown last time we spoke, Sue, so it's a real privilege to be here today, and welcome everybody who's joined us. So I'm going to just do a snapshot of personalised midwifery care and actually lead you and signpost you to many resources. Let's just share my screen. Sorry, just frozen for a minute. We did practice this beforehand, and it's not moving, so just give me a minute. Technical support. Just not able to move the slides at the moment. Shall I stop sharing and share again? I think that's probably it. Excuse me a minute. From beginning. Slideshow. Beginning. Let's try this. Yes. Okay. Sorry about that. There's always a blip. So yes, it's Epilepsy Awareness Month. And why is it important to be talking to you all today? Well, there is approximately 2,500 women per year with epilepsy who give birth. And so you'll probably come across at least one person within your practice, and it's an opportunity to learn more about epilepsy. But when you meet that person, you won't know what type of epilepsy they've had and what sort of experience they've had regarding their epilepsy. But we do know there is an increased risk of premature death in people with epilepsy, and the mortality rate in pregnancy and for 12 months following pregnancy is 10 times greater than the general maternity population. And particularly when we look at sudden unexpected death in epilepsy, when we do the embrace reports and chapter group writing, we're always astounded by how many women actually pass due to sudden unexpected death in epilepsy. And out of 17 women with epilepsy, 14 of those died due to SUDEP in 2019 to 21. So when we look at risk factors for SUDEP, we know age between 20 and 40 is a great risk. And of course, that's when a lot of our maternities appear. And also understanding risk isn't constant. So you might risk assess somebody at the beginning of pregnancy, but that can change even just 4 weeks down the way. We also know that the highest risk of SUDEP is somebody having tonic-clonic seizures, especially if these are prolonged or if they occur from sleep. And we always say avoid lone sleeping, lone and prone sleeping. Certainly in my practice, I've been seeing more people with learning disability having babies in the last few years, and they are at increased risk of SUDEP due to multiple reasons. We also see reoccurring features such as obesity and multi-comorbidities, and certainly people from vulnerable backgrounds. But the most recurring feature in epilepsy deaths is non or poor adherence of anti-seizure medicines. And this may not have been due to the woman actually stopping the medicine. It may have been a health professional who's advised them to do so, or they may have recently transitioned from a different anti-seizure medicine and the current medicine isn't providing the same seizure control. And also fragmented care. And this is where midwives come into play, because midwives can be the essential conduit between all the services, because they're the ones who can outreach. Now, when you meet a woman with epilepsy, I want you to think about the journey that's gone before them, because not everybody with epilepsy will have had the same experience. They would have all had it for different lengths of times. The diagnosis may not be sound, because many people can be misdiagnosed with epilepsy or non-epileptic attack disorder characterized by dissociative seizures. You don't know what type of seizure they have. You don't know the frequency. You don't know anything about their risk behaviours. And you don't know how epilepsy has affected their education or employment. And also the gynecology effect, you know, have they had a problem with fertility? And also if they're from a different ethnic origin, or they're from a different country of residence, they may have all sorts of stigma that has come with them as well. And also it's going to be reliant on their support network. I want you to consider the impact of that journey. Now, most certainly this does not apply to everybody, that they have a multitude of stuff that goes on that's negative, because I'd say at least 60% of my patients don't experience negativity with their epilepsy because they've had good care. But not everybody's had this journey. Sometimes, as a result of their seizures, they've developed post-traumatic stress disorder, or they can develop that as a result of all the potential things that this could put them at risk of, including status epilepticus, an increased risk of sudden unexpected death in epilepsy, and also risk of drowning. And people saying, no, you can't do that. And of course, if you've got ongoing seizures, you can't drive, and that limits what you can do. That might affect your employment or your education. And you're prescribed anti-seizure medicines that potentially interact with contraception, so maybe more likely to have an unplanned pregnancy, but also this underlying fear of having a baby with birth abnormalities or syndromes. And it may be that your patient has already had children, and it may be they have had a child affected by their particular medicine. Certainly for some people with epilepsy, they suffer stigma and loss of independence, and with that becomes dependence because they feel disabled, and they can in some cases end up in relationships that can become coercive. And of course there is also a suicide risk, and that can be related to the medicines itself, or it can be related to their circumstances. So when you see a woman, I don't want you to just hone on epilepsy. I want you to think of that mum, that future mum, as an individual with her own story and her own history and her own experience of epilepsy. I want you to understand her concerns and risk factors and work with her to reduce adverse outcomes, because you're going to be at the beginning of her journey, mostly. However, some epilepsy specialists, such as myself, get to know before the midwife does, because the women let us know. So to help you with this process, I've designed a maternity epilepsy toolkit. It's been an iterative process, and please, if you have any feedback, I'd love to hear it, because then I can adopt it to your needs. So this is all designed around the needs of women and their families, other health professionals, but also feedback that I've had, and being an Embrace assessor for nearly 8 years. And so all the wisdom that I've learned from that, I've been able to instill into the toolkit. It is on my website, that's desperately needing to have an update, just that it's more compatible with phones, but all the information is there. Now, when you're at the booking appointment, if you find out somebody has epilepsy before the booking appointment, it's an opportunity to alert the obstetrician and neurologist or epilepsy specialist. But if you didn't know before this woman disclosed that she has epilepsy, then please make an immediate referral to the obstetric and neurology team for triage and categorization of risk. Now, I can't be explicit about this because some people have a team that come to the obstetric unit for a joint clinic. Other times there may not be a permanent neurologist or epilepsy specialist, such as on the Isle of Wight. So, you know, I don't actually know your circumstances, but if you don't have that facilities, we have the maternal medicine networks now where you can refer. when you take the history and you make the referral, please include the type or a description of the seizures. The woman might not know what they're called, or she might have her own pet name for them, but what she can do, or her partner can do, or family member, is give you an explanation about them. Please find the date and time of the last 3 seizures. This is really relevant because of the fact that if a woman has had seizures in the last year, she's potentially at higher risk of seizures during the pregnancy. I want you also to find out about the anti-seizure medicine that she takes. Have a good conversation about that. Find out the dosage, not only the time she takes it, but how she takes it. How does she remember to take it? Where does she obtain it from? And how does she ensure that she's always got a prescription? And it's at this point you can contact the neurologist or epilepsy specialist just to find out whether they want an anti-seizure medicine serum level, such as lamotrigine. Find out the other medicines she's prescribed, including over-the-counter, and whether she's taking folic acid 5 milligrams or 400 micrograms. Find out what's relevant for your trust, because ours is still 5 milligrams if you're taking anti-seizure medicines, but it does differ around the country. And if known, find out the name and location of the consultant neurologist and epilepsy specialist nurse, because it may be that the woman in front of you is delivering in a different unit, but you'll still be able to have the support of this woman's neurologist and epilepsy specialist, which is very important, but I would always advise to refer to your team as well. So how can you reduce risks? Well, because I like to base everything to women to help them take control, because at the end of the day, they are the decision makers. We call it shared decision with what they do, but it's their decision at the end of the day. And so when I get people to risk assess, I try and get them to risk assess themselves. But if the woman hasn't had the opportunity of doing this, you could just go through this list. And if you highlight anything, this list increases risk of morbidities and mortalities. And that's why I've got 20 pointers here. And I would just like you to include any of those which the woman answers yes to in your referral. So for instance, the woman was taking sodium valproate or topiramate, but she only actually stopped it 4 weeks ago. Well, that's really relevant because of the fact that she hasn't had at least 6 months on her new anti-seizure medicine. Or if she has focal epilepsy, she could be at increased risk during pregnancy, or tonic-clonic seizures from sleep. So, of course, you know, these will all then trigger the triage. But what you need to know as well, this is all in the guidelines, including the RCOG guidelines, but also the epilepsy guidelines, that women should be referred to a specialist. And it seems actually, doesn't everybody do that? Well, no, they definitely don't. Some women, I don't know if they've disclosed that they've actually got epilepsy, but it hasn't got into the records and they've never been referred, which is so tragically sad. So for yourselves, if you're community midwives, particularly, you'll be providing regular planned antenatal care with the community midwife and designated epilepsy care team. It's very important for midwives to put women down a primogravid pathway rather than a multigravid pathway, where some of the appointments are missed, because the woman needs robust support from everybody. And at each maternity, neurology, epilepsy encounter, a woman's risk factors should be assessed. And this includes sleep deprivation and stress. And, you know, sometimes, especially if you've got a little one as well, that's really hard to avoid, but you can work with the family to try and help with that. Find out about adherence to anti-seizure medicines, not just on the first meeting, but subsequently too. And also the seizure type and frequency, particularly if they're occurring in pregnancy. And I really want to focus on following up non-attendance. I think midwives are in the fortunate position to be out be able to outreach to women. Some women in some communities, particularly if they don't speak English very well, can be really reticent to come forward. And remember, they probably cannot drive either. And you might need to go to a place of worship or get in touch with somebody's aunties, as they're called in many African communities, in order to be able to locate and be able to support a woman with epilepsy from a vulnerable community. It's important to provide safety, water safety and safe sleeping advice, and that's all in the toolkit. So that's safety with bathing, safety with swimming, walking next to rivers and streams, etc. And when you're giving safe sleeping advice, remember not just to presume if somebody's got a partner that they sleep with them. Many people sleep apart, and it might be one person's upstairs and the other downstairs, or the partner always falls asleep on the couch. So remember, it's much safer to be sharing the bed with someone. And if that isn't possible, then it may be, and you can't get the person to be, if they are at risk of seizures, with a family member, it may well be you need to do a needs assessment through social care. If the woman does disclose any tonic-clonic seizures arising from sleep, that needs to be flagged urgently to an epilepsy or neurology specialist. And if the woman discloses recurrence of seizures, or she stopped her anti-seizure medicines, you need to obtain immediate, and when I say immediate, I mean if this is Friday late afternoon and you find out a woman has stopped her anti-seizure medicine, this is a red flag, and you need to be letting everybody know immediately. Obviously, you need to talk to women about consent, about information shared, but to actually ask her about her decision making, because it may be that she's too frightened to take her anti-seizure medicine because she's worrying about the potential harm to her developing baby. So she needs to be counselled appropriately. Now, to help you in the toolkit as well and to be up to date, this time I've added QR codes, and they will help a woman navigate the pregnancy journey. And it includes the RCOG Epilepsy and Pregnancy, and how the woman can self-register to the UK Epilepsy and Pregnancy Register. And they are enrolling some women to research as well. Also encourage women to download the EPS1 app so they can self-monitor their own risk factors, and it gets you to update every 3 months. It's a great opportunity to talk about first aid for seizures, and you may be the only one as midwives to actually have the partner in the same room where you can actually demonstrate first aid for a tonic-clonic seizure or for a generalized absence or focal seizure. And if you do not know that information, please also go on those links yourself in order to find that out. And there's obviously great information on Epilepsy Action website about epilepsy and pregnancy and looking after a baby. And I've had the privilege of helping with this for many, many years. And also there's a link to my website and advice about contraception. It's important you give accurate contraceptive advice because of the fact many of the hormonal contraceptives interact with the anti-seizure medicines. But I cannot emphasize enough, safety and risk awareness should be discussed at each maternity encounter. But I want you to ask the woman's narrative about her risk. What does she do to try and mitigate risk? Because this isn't about you, this is about her. And she does know so much more about her epilepsy and how she keeps herself safe than you do. So please ask her first before you start giving her the information. There's also information within the toolkit to help with the labour discussion and the postnatal checklist. And for this one, because I used to just leave a blank S-bar on the toolkit, I found that many people don't know where to start with an S-bar. So situation, background, assessment and recommendations for when they're actually writing it for someone with epilepsy. So I've done a mock one that can be cut and pasted, particularly onto the electronic records, just to help people out. Because I have just retired from the NHS, but as Sue said, not stopped working. So what to consider postnatally? Remember, there needs to be an antenatal plan already set in stone before the baby delivers, in order that can often start from 3 days postnatal. The adjustments, if the medicines have been increased during pregnancy, and give accurate advice about breastfeeding. You can get that all from ToxNet. Stress the importance of continuing anti-seizure medicines, not missing doses, because this can lead to seizures. And talking about safe feeding position, this information's all available on the Epilepsy Action website. The feeding choice should be supported, and advice regarding safety, night feeding and expressing, and try to avoid sudden stop in breastfeeding if taking anti-seizure medicines, because the baby will suddenly withdraw. And provide proactive, holistic, personalised postnatal support. And if you can keep a woman for 42 days rather than discharging her, I'd really appreciate if you do that, and you offer her community care to save her getting up early in the morning for a postnatal appointment. There's lots of resources here. So that's my website, Epilepsy Actions, the first aid poster, safety advice for people with epilepsy. This is the UK Teratology Information Service to give women accurate information about their medicines, the SUDEP and seizure safety checklist, safety and risk on the Epilepsy Society website, and the Epsimon app, and then tips for looking after a baby when you have epilepsy. And as I said, I've helped with this as well. I want to thank you all for listening to me. Hope I haven't overrun. And there's my details if you do need any further support. Thank you.
Fabulous. Thank you so much, Kim. My goodness. You make it sound, I mean, I love the sort of focus on the mother as the individual, and I love the woman's narrative of risk, because I think it's really important that we remember she knows, well, she's an expert patient, if you like, isn't she?
Yes.
And that's really helpful to kind of stick in everyone's brain. So thank you so much for sharing that. Enormous amount of information. My brain is almost full. Now, some of you watching will have questions, and if you do, just pop them in the little discussion board, and it'll come through to us after the next session. You might want to run through that again, because there's a lot of information, really good material to remember. So thank you so much, Kim.
Sorry.
But we're going out to now the double act of the evening, which we've got from the Epilepsy Action, which Kim mentioned several times, and you've seen little a lot of information from them, because they're a key charity. I'm delighted to have Alison Fuller, who's the Director for Health and Influencing at this national charity. She's had a background as an Associate Chief Nurse in West Herts. She's had a huge career, and she's also worked on the East Kent Maternity Review by Bill Kirkup. So that must have been very interesting too. Again, it's all on the website. So I don't want to take any time away from Alison or Catherine. And Catherine is the Midwifery and Epilepsy Coordinator for Epilepsy Action. She's also undertaken so many roles, including clinical leadership facilitator, professional midwife advocate, consultant midwife, and director of midwifery. And she describes herself as semi-retired. Now, these women are examples to us all. I don't think you ever retire. You just begin to choose the things you're really interested in and you want to develop. So welcome to Alison and Catherine. The screen is now yours, and thank you, both of you, for coming to join us this evening. Fantastic.
I'll just share the screen. Let me know when that comes through.
Okay. We're there, Catherine.
Okay.
Thank you. Thank you. So I'm just going to kind of set the scene really, and then hand over to Catherine. So just as obviously it says by this quite busy slide, we both work for Epilepsy Action. I've been there for 2.5 years, and I retired and returned to this, obviously to this role. So Epilepsy Action, if you could go to the next slide, that'd be really helpful, please. Thank you. So who are Epilepsy Action? First and foremost is thank you so much for this opportunity to present this project to you all. Epilepsy Action. So it's a national charity, as it says there. We cover Northern Ireland, Wales and the UK. We don't cover Scotland, but we have a reciprocal arrangement and work very closely with them. We set off in this year to set out our strategy, and it has 3 really clear ambitions. And as Kim's already alluded to, epilepsy has a really big impact on people and their lives. So our ambitions start with improving the lives of everyone with epilepsy. It can have some devastating effects on people. It can affect work. It can affect their mental health and everyday activities. And we want to be the voice of people living with epilepsy to be able to share those experiences. We want to raise public understanding of epilepsy. It's interesting to know that not everybody knows what epilepsy is, or they think they know, and all they think of is seizures, but it has got so many other elements to it. And this is one of our ambitions, is to make sure that everybody knows what epilepsy is. And to be fully inclusive. Fully inclusive really does mean about having everybody on board. Stigma, isolation, all of those issues that Kim picked up are very implicit in our work. So, as a charity, we provide a whole range of resources. And I just want to kind of give you a quick overview. We do resources both for healthcare professionals. We do a lot of templates for care plans, and we do seizure diaries. We have the drug watch, medicine shortage information. We do a lot of printable health information, which you can have access to. You just need to do orders. All of these can be through order. We advise, we provide advice to professionals through a whole range of ways, particularly our helpline. And that is available Monday to Friday and some Saturday mornings. And we have a range of people who can help advise and support people. And we also do a whole range of online epilepsy training, which can be accessed by both healthcare professionals as well as by individuals. But we very much, and we're very pride ourselves on the resource we do for people with epilepsy. We are what we call PIF-TIC accredited, which means that we go through a whole range of accreditation and are nationally recognised. We do information for about having a family. Again, the helpline answer those experienced team can answer those questions. We do a range of talk and support groups, which are online and in person. We do a befriending service. We do the free online training and the latest news. We do a range of publications that go through from professional, epilepsy professional, ET, that's Epilepsy Today. We do newsletters, and we do have a membership for epilepsy specialist nurses, but equally for any professional who wishes to join. Next slide.
Thank you, Alison. And I'm so delighted to be able to share the Maternity Epilepsy Project, which began in January of this year. And our ambition and aim right at the very beginning was very clear to improve the clinical outcomes and the lived experiences, back on, from what Kim was sharing, with a wealth of experience. Those lived experiences are very real, and it's so important that we, together, that co-production, we develop a pathway of care that includes not just pregnancy but preconception and postnatal care as well. And what we have achieved in the 11 months is we have co-developed a library of resources, which include a Northwest regional guideline, a minimum service specification, and a self-assessment toolkit, so to enable local providers to benchmark their service around national and safe standards. So some of the things Kim shared already as to where the project has originated from, but I have to thank Alison, for her vision, with all her leadership expertise and knowledge, her vision, on the back of the Embrace report, which Kim's already identified that women with epilepsy are 10 times more likely to die in pregnancy than women without epilepsy, you know, and linking into the reports from SUDEP and the fact that maternity epilepsy related deaths have almost tripled in the 3 years. So on the foundation from that, Alison joined partnership with the Northwest Regional Maternity team to fund and create this amazing and most life-changing project for women, but equally for care providers. And you know, in the last 11 months, we've undertaken lots of events and engagements with women and their families, with clinicians, to enable us to co-produce that library of resources. So when we look at the Northwest, we know that one of the biggest challenges has been around the limited national data, because unfortunately epilepsy related information is not mandatory as part of the MSDS data set. But we do know within the Northwest, approximately 73,000 people are living with epilepsy, and that roughly equates to about 1%, 1% of the population. You know, again, just some of the what Bill, on the back of what Kim said, you know, there is links with people with epilepsy living in the most deprived areas, and within the Northwest, you know, we have some of the most deprived areas within the UK. What data we do have, and we are working closely with the regional business intelligence managers to try and capture and to build a data library, is that, you know, within Cheshire and Mersey, one of our local maternity and neonatal services within the Northwest, 51% of their women with epilepsy are actually living in the most deprived areas. So it just really reinforces what we know already. And then there's lots of, you know, different publications coming out and research. There is a need to do more research, but there's also so some of the information is quite controversial. But, you know, there's a recent Scandinavian study that highlighted a 50% increase of either death or illness for children of women with epilepsy. So, you know, what we don't understand, I'm sure Kim's the same here, is why has this not got a higher profile within the maternity agenda? It's screaming that, you know, we need to do things differently. So the project, you know, as Alison said, being inclusive is so important for, you know, within the values of Epilepsy Action, and that shared decision making, you know, around. But the woman, you know, Kim's quite right. The woman is the only decision maker. You know, as a service provider, our role, I'm very clear, our role is to ensure that each person has all the information they need to make the right choices for them and their family. And throughout the project, we have had extensive partnerships and relationships built across the Northwest. And I think what's different to this project is we have also included, it was important to us to capture the young voices, because ultimately they will be our future service users and families. But equally, whilst we know that you know, the young person pregnancy rate has reduced over the last 10 years, they still choose, or maybe unplanned pregnancies occur. So it's a different cohort of people that we need to get the messages right. We need to get those communications and that information right within our future pathway to create that sustainable model moving forward. Well, the first thing that we did was undertook a gap analysis. And some things weren't really a surprise. You know, in previous reviews of systems and care pathways, it comes up time and time again. And it's no surprise that there's huge variation and gaps in clinical practice and available resources. And Kim, you shared this too, you know, in your work, and I'm sure you've seen it when you've been reviewing Embrace investigations and reports. I think what we found is the the big elephant in the room around this is around that there's no preconception pathway. It's around looking at who will own this, whilst lots of the documents, the national documents, refer to preconception because that is the foundation of increasing healthier pregnancies and healthier outcomes for women and families. It doesn't appear that there's any clear ownership and direction across the Northwest. We know that with, as part of the gap analysis, there's huge variation in language, and that can be quite confusing because what we're trying to establish is a pathway that is for all care providers, and when we're changing things like AED, ASM, that can be quite confusing. We noticed that some centres didn't have a maternity specific guideline, and it can be quite, sometimes when you're looking at a care pathway, it felt like trying to find a Russian doll. It was like there were so many, or layers of an onion trying to unpick where to get that information from. Within the guidelines, we never saw anything that related to first seizures during pregnancy, within local guidance. And, that can happen for some women, and is much needed within the clinical guideline. Often there was, Kim had spoke about comorbidities, learning, she's experienced more women with learning disabilities and having epilepsy, but also, increased links of mental health issues that women with epilepsy have higher risk of developing. So there's lots of things there for us to work and to find a really robust pathway moving forward. Next was we had several listening events with women and with young people, and it just reiterates what we've heard is the same as what Kim has shared. That women often feel very isolated and under pressure, repeatedly not being listened to. The listening events were very emotional, and it was quite difficult to hear, as a midwife. And one woman shared that she wasn't believed when she said, "I've had a seizure." The staff did. How? It just is beyond my conception of how a clinician can do that. Women felt that the NHS knew nothing. And we've talked several times, throughout the programme. It did feel like we don't know what we don't know. Not for all. There was good area of care, and that was mainly centred around the amazing work that the epilepsy specialist nurses and their teams provide, and equally as the maternal medicine networks are being embedded within the regions. And there was lots of issues around care that they'd received, and that was around lack of support, poor communication between maternity and epilepsy services, and the lack of knowledge from staff kept coming through with each of the listening events. So there was lots of us there, lots of learning for us to embed within the pathway. We had some young people's voice, but we felt that we wanted to get a wider understanding. And out of 28 responses that we had from the survey, it was really good to see that, two-thirds, we'd like more, but two-thirds had received contraceptive advice. Unfortunately, only 7 had received information when actually wanting to plan to have a baby. And I think what was, I think, one of the key things that we've taken away from this is that whilst I think sometimes there's an assumption that the younger population are quite digitalized, they actually 85.7% wanted face-to-face discussion with either a nurse, a midwife, or a doctor. But they did prefer, in terms of when we're sharing information and resources, the majority of them did prefer the app-based platforms. And I think what, you know, key things to take away is around what was most important to young people around contraception, and that was around information about their epilepsy, but particularly, you know, around the interaction of taking anti-seizure medication. So we've, again, more learning that we were so privileged to capture at this during the project. So we then had clinical listening events with midwives, with obstetricians, with neurologists, with GPs, and it was quite diverse, the clinical listening events. And you know, there were some similarities. A main thing was around the variance of joint services. It was often inequitable, and that was compared with diabetes services, you know, where often there's very robust and established teams, even within small local providers. And within the bigger units in the maternal medicine centres, that wasn't so much of an issue, but where you've got smaller local providers, they didn't have the same staffing to provide services, and subsequently they became quite inequitable. A theme came up time again around education and lack of access, lack of knowledge, lack of being released, you know, because, you know, there isn't any unit that's working above and beyond for the last 5 years at least, you know, so it's so difficult on top of the vast amount of mandatory training. You know, I think a midwife in the last trust, it was nearly 3 weeks mandatory training that they needed to complete. It just keeps adding and adding, but we do need to prioritise epilepsy for clinicians. We then undertook a midwifery survey because we you know, we're looking at the future as we're still keen to improve the experiences of clinicians on the front line, and we wanted to capture midwives' experiences in terms of their self-assessment of their knowledge of epilepsy when caring for women, but equally around how confident they felt. And we were really delighted to have 60 midwives that completed across, the survey across the Northwest, and that included a range of midwives from all fields of the pregnancy continuum, antenatal, interpartum and postnatal, but equally we had specialists, midwives working in a specialist midwifery setting. And you know, you can see the bottom point there that we did have quite diverse experience of midwives, you know, from 4 to 38 years working within the NHS. Sorry, just there we go. And what we found, some of the numbers don't quite add up because they didn't put, not every midwife put in where she was working, but we found that there was no midwives working within preconception care. And when we asked the midwives to self-assess, we asked them to score themselves out of 1 to 10, 1 being no knowledge, to 10 feeling that they have expert knowledge. And you can see in each of the areas of pregnancy there, you know, we only had very small numbers that scored 6 and a 7. I think it was 2 for 7 for antenatal knowledge. You know, the rest were 6, and there was, the majority of them were 1 to 3, you know, no or very little knowledge. So that's something that we need to, they're the next steps for Epilepsy Action, to think about how we can support frontline midwives and clinicians also in enabling them to have all the information they need to deliver safe care when caring for women with epilepsy. And what we found, just to summarise the project, we found that the project is so far-reaching. You know, we feel confident that the relationships between midwives, obstetricians, and neurologists across the Northwest have improved because of the extensive networking that we have undertaken. There is a real appetite within the region because they've acknowledged around the lack of consistency and robust pathways because of the huge variance. The project very much, very much mirrors the national maternity agenda in terms of, embrace, in terms of the NHS 3-year plan. We've talked about the core 20 plus 5, both for adults and children. So what we're trying to achieve is much bigger than writing a guideline or doing a pathway. It's much bigger. And what we have learned, the value of working with third party, that I think I personally underestimated that, and it is the future, I think, for future maternity services, because, Epilepsy Action has got such a vast source of knowledge and skill set and members within their team that have just accelerated the ambition of the project. And that's it, I think. Any questions? Thank you very much.
Fabulous. Thank you so much, Catherine and Alison. That was, well, and Kim again. That was really fantastic. It's a lot of material, and we've got some questions. And I know we're running over a little teeny weeny bit, so please, those of you who are still with us, just bear with us for a few more minutes, because I know there's some really good questions that have come through, and we have our speakers here ready and willing to engage. And I've got a question, and I have to remind you, I had to turn away over to my other screen to get the question so I can field them to people. So I have a question from Sally Ann Remnant. Hi, Sally Ann, who says, please remind me why there is a risk of more seizures in pregnancy if the woman has had seizures during the year before. I think that's a Kim one.
Yeah, so I mean, the first study that identified that was from America, where they actually looked at the number of seizures occurring during pregnancy. But most definitely the hormone impact and the impact of hormones on the anti-seizure medicines, and also women taking the medicines because of the fear of what these medicines can do to their developing baby. Also, they're more likely to have sleep disruption. And when we come to the postnatal year, that is paramount because of being disturbed by a young baby, but also the same that some women can be extremely reticent about continuing their medicines when they're, for instance, breastfeeding, because they're worried that once again this is going to cause their baby problems. So that's why these conversations all have to be out in the open. But thank you, Sally Ann. That's a really good question. And yes, it is mainly because of pregnancy itself, the physiological changes and how that can impact on the woman, but also the impact on of the hormones. Yeah.
And I think you highlighting the woman's anxiety about passing her medication to her baby, either unborn or breastfeeding, is quite a big thing, especially since there's quite a lot, it has been a lot in the media, sometimes a bit scaremongery without the information. And I think this is where the charity really comes into its own, with all the information and the website information, and the midwife's role in being that you called it conduit or conduit for the woman. So thank you. Great, Sally Ann. Okay, I've got Jo DeGuston from Ames. And she said, is this, and I'm not sure who, this might be a shared question. Is this sort of issue presented in every pre-registration course and offered as regular continuing professional development in trusts?
Okay, I could start answering that, Sue. Across the Northwest, we did. You might have missed on the stakeholder and the partnership slide. We did liaise with the local universities across the region, and the responses that we got was that yes, epilepsy is often we're caring for women with epilepsy is part of for some universities it's in every year. They'll have a different scenario. Some will have guest speakers of consultant neurologists, but it varied. It very much varied. We know in the Northwest as well, the Maternal Medicine Network have just set up a level 7 module for maternal medicine, and epilepsy will be very much a component on that programme. So we're excited to be part of that, so it varies, but we need to have consistency across all universities, don't we?
And I think your project actually illustrates what can be done. And I'm aware very much as a midwife educator that each university will have a slightly different model of what and how much they focus on it. Alison, you wanted to respond too. Fabulous.
Yes, obviously going down this approach and with building on what Catherine's just said is that what we're trying to look at is a lift and shift model. So what we learn here,
I love it. Lift and shift.
A lift and shift model, so that what we've found we can actually take further afield and try and introduce it nationally. That's one of our objectives with this. See if we can get widespread adoption. So the training and education program is something again that we want to try and raise that profile and make sure that it's accepted, or at least acknowledged. It needs to be embedded through all training programs. It's a big ask, but we're on the mission.
Fabulous, thank you. And Kim?
Yes, certainly my experience of midwives has been different every single midwife you speak to, but having lectured in some of the universities and found out actually how much epilepsy training student midwives are going to get. Some will cover all the medical conditions in half a day or an entire day, and that's it. And others will come out and do work experience with you. So I've had probably maybe a couple of hundred midwives, student midwives, coming to do work experience with me. But others, if that's not their field, and then they haven't got that personal interest, then they don't have to do it. And that's the problem. We have a thing called green brain in midwifery, and I was actually designing a module for it, but it was actually really difficult to actually integrate that within the system and get people to that be part of the statutory study, because there are so many statutory study midwifery days, and epilepsy is not on their agenda, although seizures are because of preeclampsia and eclampsia. So yeah,
I think I have to say, as a midwife, a student midwife, I learned the most when I was looking after someone who actually had epilepsy, because then you have to stop and think, what does this really?
Can I just add, Sue, to Jo and everyone, as part, one of the components of the, can everyone hear me?
Yes.
Can people hear me?
Yes.
As part of the service specification, we have asked all providers, or we will be asking all providers to
Oh, we might have lost Catherine for a minute. So we'll hold that, and I'll go to, I had another question from Jane Marshall. Hi, Jane, who says, do you have any advice for individuals with epilepsy who may wish to pursue a career in midwifery? That might be one for Kim.
Yes, so I've had a few patients who've decided to be nurses or midwives or doctors or pharmacists. And actually what you do need is the support from an epilepsy specialist as well, because she'll often he will advocate for you. I think providing there's reasonable adjustments within the workplace, especially when it comes to the long shift patterns or the night duties, the trusts usually are extremely understanding. I think it's extremely important to be choosy about where you do your training. So have a good look around and to make sure there's a good equalities service. Yes, I've had good experience, and some people with epilepsy becoming excellent midwives and wanting actually in the end to specialize in epilepsy themselves, which is great. Yes.
Yeah, and that, I think the kind of idea of making looking at where you're going to go and being
Yes.
choosy. I think that goes for everybody, but that's especially important if you've got additional stress.
But of course, the first thing you need to do is try and make sure you're looking after yourself in
Yes,
order to be able to
absolutely.
help others. Yeah.
Thank you. Okay, thank you for that. And we have Joe again, Joe D'Augustin, asking another question. Hi, Joe. Is there any data around the percentage of women with epilepsy who are placed on a full continuity of carer pathway? Gosh, that's a difficult question, Joe. I'm not sure would you know
I
the
can
answer,
answer.
Kim?
Well,
Or Catherine? Catherine's back
I
with
think
us.
yes, I'm back in the room. Thank you. I also have another role of being the clinical project lead for continuity of care within the Greater Manchester, and I think the answer in short is no. But what we have done at Epilepsy Action as part of the guideline and the service specification is that we have recommended that women with epilepsy are cared and are prioritised to be cared for on a continuity of care pathway.
Makes absolute sense, doesn't it? All women should be, but you have to prioritise. Thank you.
They should.
They should. Okay, and we've got a question from Jane Parnell, sorry, Jade. And she says, thank you for an interesting talk, Kim. Wondered if you could detail if you provide preconception counselling, and if so, how do you support and prepare women with epilepsy who inform you that they'd like to try and become pregnant, especially as it can take a while to titrate meds? Whoa.
Right. So to titrate meds with newly diagnosed epilepsy.
Well,
so my service.
Just women with epilepsy who are looking at preconception counselling. How do you do?
So I usually used to see women from the age of 15. So I don't do one preconception appointment. That's my biggest message, that preconception care should be actually at each appointment that you follow up somebody providing continuity, which I've always done, of carer, in order that that pathway is embedded and the information that you provide is planning for future pregnancy, no matter what age. With 50% of pregnancies unplanned in this country, that is vitally important. You will have some women who have an intrauterine system or something like that, or an hormonal implant, if it doesn't interrupt with their anti-seizure medicines already in situ. You may have been seeing them for preconception counselling over the last couple of years. And the titration of the medicine part of that, first of all, is looking at their physical, social, and mental health. But the titration of medicine, sometimes we titrate up before the woman becomes pregnant, especially to protect them in the first trimester. So if somebody comes through on an extremely low dose, and as soon as they've got this massive human chorionic gonadotrophin circulating in the first trimester, for some of the drugs like lamotrigine, it can make those levels plummet. But that's very individual once again. So we'd be obtaining preconception serum levels, but we don't treat the levels, we treat the woman, because that's vitally important. And so the journey can be that you're supporting somebody, which I have probably thousands of women changing from one medicine to another. And during that time, you have an onus to actually be responsible to make sure that woman isn't going to conceive whilst taking 2 of the anti-seizure medicine, because you step one in and then gradually step the other one out. But also you want a period of time where you can assess the seizure stability after that's gradually been stepped out. Before the woman becomes pregnant, and then you feel much more assured as to how they're going to be in the pregnancy. And of course, the other massive bonus of doing this and supporting women over years, and I know one woman, I think I'd seen her over 400 times, is when you've seen women so many times over the years, is you build up such a good relationship. And it isn't just you know, you're networking out to neurologists, psychiatrists, obstetricians, etc. But so preconception counselling, the important thing to remember, isn't one appointment. It's it's a building of a relationship for when somebody potentially could get pregnant. That's the ideal time to start from transition and go right through to motherhood. Not all centres have that opportunity, but I'd certainly recommend it. And on preconception counselling, I'm sure everybody's aware of this, it is not funded. So in obstetric and maternity and midwifery services, and that's the biggest problem. And even though it's in our guidance, and that's how I was able to offer a preconception counselling service, it's in our guidance, then the majority of midwives don't do that. Not everybody, but the majority.
I think this is where the continuity of care comes in, and also the multidisciplinary working, which you've all illustrated really brilliantly this evening. I'm just going to squeeze another couple of questions in. I've got Jade Parnell again. Thanks, Catherine and Alison. Such a helpful session. Is there a place that these data have been published that can be referred to? Because it was a lot of information from the Northwest project.
We're just at the stage of fine tuning the documents, last minute amendments and things. So once that has been ratified within the region, and then all of those are shared on the internet. All the regional guidelines and things are shared. But as Alison said, our ambition is to look at how we can share this nationally. Have a national footprint, because it's so important.
So presumably when you've published formally, it will be on the Epilepsy Action webpage or anywhere. So Jade, keep your eyes open. That's where it'll be. Fabulous. Thank you so much.
It's interesting as well, just to pick up on Kim, we are trying to really push looking at how can we influence preconception as well. So that's part of the rollout of this process. I
can see that sneaking in somewhere.
I think so. If I could just add with the preconception, what we have got a greater influence is preconception at postnatal care, for next addition to the families, and because we've got the team around there that can facilitate that. We just need to ensure that they have the knowledge to do that.
Yeah, and I think that the project actually illustrates a much more integrated approach to the whole care package for women, which sounds fantastic. Now there's one more question, and then I've got a comment or two. And the question, we've got Juliet Samuel. Hi, Juliet. Nice to hear from you again. And she says she's in Essex. Apologies for being late. Well, we're late too, doesn't matter. Do you see this project to be replicated in other areas, which is kind of what you said? So it becomes nationwide, Scotland exempted. Maybe not, maybe. So to provide personalised care, then it becomes shared knowledge for these women. I think I know the answer to this. Everyone's thinking.
Yeah, that's our ambition. But also we've also been, the information that we've got from the maternal medicine network is that we've very much set the trend to use this approach across all maternal medicine conditions, because I think, I've not got the evidence, but I think, it's likely that the same challenges are there with other conditions, in terms of how best to care and that knowledge and support for the frontline workers.
Absolutely. Thank you. Now I'm going to do a few comments. I've got another comment from Jo, who says, and she's with AIMS, as people will know, and she says, Catherine, brilliant focus on feedback from women. Yep, not listening to us, not believing us. That's totally unsurprising, sadly. Time after time, we find that sort of behaviour within a context of fragmented, industrialised, dehumanised care, lack of continuity. And then I've got from Charlotte Harris. Hi, Charlotte, who says, as a currently pregnant doula who has epilepsy, I really appreciate the conversation around women-centred care and trusting in the women's own risk assessment as an expert of their epilepsy. I would love conversations and resources shared with health professionals to highlight the differences in types of seizures. I have absent seizure epilepsy and was met with shock and horror when I mentioned how many seizures procedures I can have and how frequently. Oh, so thank you for that, Charlotte. That's really, and I love the journey for the woman, because for me that really focuses, and I think our three speakers have focused beautifully on women as well as midwives and students. So I have to say thank you. And I'm going to bring it to a close. And I know there's probably hundreds more questions. We'll have to get them back, won't we? And they can't retire. There's no retiring. And I always say this hour is the fastest hour in the whole week, in the whole month at all. So I want to say a big, big thank you to our speakers, to Alison, Catherine and Kim, for joining us, because it's been fantastic. And there's so much information. I know many of you will want to replay it, and you can replay it through the podcast, or you can just replay the whole thing so you get all the finer detail, because there's a lot of information, especially for those of you who are, for example, doing projects. It's been really useful. And there's some superb references that Catherine and Alison provided, and obviously through Kim's website, loads of information for you there. Now I'm just going to say a big thank you to Catherine, Kim and Alison. Also Angelo is in background, making sure we're all recorded, so it'll all be ready for you to play again and again if you need to, and to share with your colleagues, because as I said earlier, that really helps you understand and shares out this information. People need to know about this. Do you think about the sort of the deprivation as a major feature, about the numbers that are involved here? This is not a tiny number of women. These women you're going to meet at some point. You might not have met yet, but you will. So that's fantastic. Also, thank you to Paul, who's been feeding me through the questions, which is fantastic. And I'll reiterate, the resources are available there. Facebook, the podcast will be available, and the whole thing will come through again on the newsletter next week. Next week, we've got a special kind of educational feature with some questions. We'll be up in Scotland for the Scottish Festival next week. So I can't say, well, I could say register for the Scottish Festival next week, so there's still time to do it, but you might start looking at the London Festival in February 2025. Can you imagine it? Oh, it's frightening. So in the meantime, take care of yourselves. Thank you so much for being with us, all of you, and we'll see you next week in Scotland. Bye.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.